I'm Dr. Tracy Papa. I'm a maternal fetal medicine physician, but I may not be your physician. So if you're not coming to see me in the office, remember, I'm not your doctor, and nothing on this site should be construed as medical advice. You always want to check with your doctor or your provider for any questions you have about your pregnancy. Hi, it's Dr. Tracy Papa. Welcome to the channel. If you're new here, I'm really excited to see you, and I want this to be a place where you can ask questions about your pregnancy. Whether you're high risk or high maintenance or a mixture of both, this is the place where you're going to get a lot of useful information and support for your pregnancy. If you like what you're seeing, don't forget to subscribe to the channel and turn on your notifications so that you can be the first to know when something new comes out. Hi again, we are back with Sarah, our type 1 diabetic. This is part 3 of her story. Today we're going to talk about how we plan for her delivery. I hope you enjoy this. So now we're set on this path of twice weekly visits, monthly ultrasounds to look at the baby's growth. Once or twice a week, we're looking at Sarah's blood sugars and making sure that they're staying in the normal range. So here's where the path can diverge a little bit. Glucoses are hard to control, and insulin requirements really do go up in pregnancy. So let's say in Sarah's case that her glucoses are getting really difficult to control. They're going up, we're going up on her insulin. She's trying to do the right things, but her glucoses are really bouncing around. They're going from 200 to 50, and she's having trouble keeping them in the moderate range where we want them. Well, this is going to help determine when we deliver her baby. If the glucoses get a lot more difficult to control as you get closer to your due date, then we may make a decision to deliver the baby a little bit earlier than your due date. So anytime after, 34 weeks or 36 weeks or 37 weeks, if we're reaching the point of diminishing returns, then remember that there's a higher risk of stillbirth when you have uncontrolled diabetes. And sometimes it's better to have an early baby that may be in the NICU for care than to consider the alternative of not having a live-born baby. In Sarah's case, we're saying that her glucoses are getting a lot more difficult to control. One of the things that we can do is put her in the hospital for the last few days leading up to delivery. And the last few days of glucoses are pretty important in determining what the baby's initial glucoses are going to be after delivery. If the glucoses have been really high, then remember that the baby's getting all this glucose from Sarah, and he is starting to make a lot of insulin to try to get those glucoses down. Think about what happens when Sarah delivers the baby and that cord is clamped and divided, and the baby's still making a whole bunch of insulin, but not getting that glucose anymore from Sarah. The glucoses just go way, way down. And this is a fairly common reason why babies are admitted to the intensive care nursery for IV fluids and glucose until those stabilize and we can start feeding the baby and get those blood glucoses better regulated. Let's take another path. Let's say that Sarah's glucoses are outstanding. She's doing a great job of keeping them under good control. So we're seeing her twice a week. We're looking at fetal growth monthly, and we're getting within a month of the due date. We have talked about a plan, but now it's getting real, and we need to say, when are we going to recommend delivery for this baby, and how are we going to recommend delivery? Well, a lot of it depends on how well your glucoses are controlled. In Sarah's case, we're saying they're very well controlled, and her third trimester A1C has come down to 6. So life is really good. Her baby is moving, her fetal testing looks great. So in that case, we're usually going to recommend delivery by your due date. So it doesn't necessarily have to happen really early. If you go into labor on your own in the weeks right before your due date, fantastic. We want to take into account how big the baby is. Remember, with diabetes, sometimes even if your glucoses are pretty well controlled, babies can really grow bigger. And growing bigger means a higher risk of birth injuries. So remember that the head is the biggest part of the baby. It's supposed to come out first so that the shoulders and the rest of the body just slide right out. When you have diabetes in pregnancy, babies can grow really big through the shoulders and abdomen so that when the head comes out, the shoulders and abdomen don't want to follow. That's a really scary condition called shoulder dystocia. And sometimes we have to work really hard to get babies out, or we have to do a cesarean delivery as an emergency, and babies can be injured. They can have shoulder injuries, nerve injuries. You can have pelvic floor injuries from us tugging and pulling and repositioning you, trying to get that baby out. So we prefer for that emergency not to happen. So we're following the weight, the estimated weight of the baby. In Sarah's case, we're going to say she is 38 weeks. She's 2 weeks from her due date, and we're getting an estimated fetal weight of about 7 pounds and 10 ounces, which is a pretty average weight for a baby at that point. So in her case, we're just going to keep following her twice a week and keep testing, and then talk about inducing labor if she doesn't go into labor by her due date. Because when you get to your due date, even if your glucoses are really well controlled, not a lot of good happens after that. Your placenta is more likely to start to deteriorate a little bit. The risk of stillbirth becomes higher. And if your glucoses are pretty well controlled, if you haven't had the baby, it's just going to keep on growing. And then you can take a risk of having a baby that you won't be able to deliver vaginally. So we have made the decision that we're going to induce labor at 40 weeks or on her due date if she hasn't gone into labor on her own. So when Sarah comes in to have labor induced, her cervix is dilated, we're going to say 1 centimeter. So it may take a while to what's called ripen her cervix. We give her medicine that helps her cervix get soft and mushy so that when we start medicine to start contractions, then labor can progress a little bit quicker and more smoothly. And when you have diabetes in pregnancy and you're on insulin, whether it's an insulin pump or you're taking insulin injections, we usually stop your scheduled insulin in labor, and then we put you on an IV insulin infusion. And we titrate that up and down depending on where your glucoses are. We try to keep them between about 70 and 110 during the labor process. So if your glucoses drop below 70, then we might add a little sugar to your IV. If they go up above 110, then we're going to turn on this insulin drip at a low level to keep your blood sugars exactly where we want them. So we usually do finger sticks every hour or two in labor for well-controlled diabetics. After you have your baby, whether you deliver vaginally or by C-section, and as soon as we get you started eating some food again, we have to recalculate your whole insulin regimen. Usually we start by putting you on approximately half of the insulin that you were taking just before delivery, because your insulin requirement drops that fast. And we spend a few days trying to see where your glucoses land. So we may put you on what's called a sliding scale. It means that we check your glucoses before or after you eat, and then we give you doses of insulin based on what your glucoses are. Then after a day or two, we figure out what your total insulin requirement has been, and then we put you back on scheduled insulin at that dose. If you weren't on insulin, if you're a type 2 diabetic and maybe you were just on metformin or an oral medication prior to pregnancy, it's possible that we may be able to put you right back on that and stop the insulin altogether. Sarah has done a great job all through her pregnancy of getting serious about taking care of herself, because remember, it's important not just for the health of your fetus, but you want to live a healthy life and you want to see your baby graduate from high school or college or trade school or wherever your trajectory takes you. Thanks for watching Sarah's story. We really did throw everything at her in terms of complications that someone with diabetes can have in pregnancy. Remember back last fall when I had a diabetes course ready to launch? Then I got COVID and all those plans got derailed and delayed for a little while. That course still exists and I'm launching it next week. Attached is the introduction to the course to give you more information about what's included. Check it out because I think you'll like it, especially if you have questions about how to manage your gestational diabetes. The cart stays open for a limited period of time, so the first few people to sign up are going to get all of this information at a greatly reduced price.
Welcome.
I am Dr. Tracy Papa, and this is a course about how to manage your diabetes in pregnancy. I'm a high-risk OB specialist, so I see diabetic patients every single day. Pregnant women who become diabetic and diabetic women who become pregnant. The process is pretty much the same, and the advice is going to look very much the same. When you get diagnosed with diabetes, it can be very confusing. You're overwhelmed and inundated with a lot of information, and there doesn't seem to be any agreement on how to eat for diabetes, whether you're pregnant or not. Some diets have more or less calories, higher or lower fat, more or less carbohydrates. What we're going to do in this course is put it all together for you and give you the training that you need to become confident about how to prepare meals for yourself and your family that are going to work for you. It's going to be tailored to your taste and interest so that you don't have to eat something that you know you're just not going to like. The course is a 4-week course. It's a 30-day course. And the transformation starts on day 1, so you don't have to wait till 30 days to see some big reveal. I love before and after pictures as much as the next person, but I also want something that I know is going to work starting on day 1, and that's what you're going to get right here. So the preparation day is the first day. That's where we're going to talk about what you need to get rid of from your pantry and what you need to stock it with, and how to grocery shop and how to plan your meals. Weeks 1, 2, 3, and 4 are going to build on the previous weeks. So you're going to learn some great habits. You're going to stumble and fall and fail. You're going to figure out a few foods that work great for you, and you're going to discover some foods that you might need to reduce or avoid because they're just not working for you. The last day, day 30, is your launching day when you're going to know with confidence how to shop for groceries, how to prepare a week's worth of meals with no problems at all, how to eat out at a restaurant so that you can be with your friends and feel like you're not deprived or sitting in a corner, but how to go forward and know that you're going to manage this okay. Not to be a downer, but diabetes in pregnancy is a very strong predictor of diabetes in life in general. About 60 to 70% of women who have diabetes in pregnancy are either going to stay diabetic or become diabetic. The good news here is that you've got some control over this. If you learn the good habits, if you learn how to eat well, if you learn how to move your body, you can affect that risk a lot. So this course is for serious people. It's going to be fun. We're going to have fun. We're going to laugh together, but you have to be serious about this, and you can't plan to cheat. You also can't be too hard on yourself. There are going to be failures, just inevitable failures. We all do. Even if you're eating the right things, sometimes things are not going to work for you, and it can be really frustrating to see a high glucose when you did everything right. We're going to learn how to troubleshoot. You're going to make some improvements, and you're going to be really proud of yourself when it's all over. So let's jump in.